what I'm going to try to tell you is that health does not equal health care, and that's important in healthcare reform because I am quite certain that we will not realize the benefits of healthcare reform if we don't recognize what are the larger structural drivers of actual health outcomes. And our healthcare delivery system is a system that is based basically on 19th century understanding of health. It's based on acute disease, it's based on infectious disease, it's based on injury. It is not based on chronic disease. And chronic disease requires a very different type of healthcare delivery system, which we do not have. We have death certificates in our county. When you die, I joke around that you're not dead until I say you're dead in my county, and it's true because I have to sign the death certificate basically allowing the body to be cremated or buried. And you can take those death certificates, you can tell what somebody died of, you can tell how old they were, you can tell what their race, ethnicity was, and where they lived. And you can take 4 pieces of data from death certificates and actually look at the distribution of death in a place. In my case, in a county. We have about 10,000 deaths a year. We went back 40 years, so we looked at over 400,000 death certificates to try to figure out what was going on with death. Because death, while it's not the most perfect marker of health, it's relevant to health. How people are dying, when they're dying, what they're dying of, who's dying when. So we did that, and we went back to the 1960s, and we looked at, and in order to do this, and maybe you talked about this in your statistics piece already, but you have to use existing data sets, and one of the most common ones is the census. And the census, as far as race, ethnicity went, didn't talk about anybody else other than white, black, and other until 1990 is really when it got sort of specific. 1980, there was some ethnicity added. So if you want to go back before that, which we did, you can only talk about white, black, and everybody else is other. So we did white and black here. We went back, and this is in Alameda County. And in order to figure this out, you use death certificates and you use the census, basically. And you could figure out life expectancy over time. And what we see here is that life expectancy is different for African Americans and for whites. In 1960, the gap in life expectancy was about 2.3 years. And in fact, when we went back to the 50s, where the death certificate data started getting a little bit spottier, but it was good enough to actually note that there was no life expectancy difference in the 1950s in Alameda counties between blacks and whites. In fact, African Americans had a slightly longer life expectancy than whites in the 1950s in Alameda County. But 1960, 2.3 years. By 20 years later, it was up to 5 years. And now it's closer to 8 years. And that surprised us. We thought, with modern medical technology, new pharmaceuticals, all of these medical marvels, that this should be a gap that's narrowing rather than expanding. So that expansion troubled us. And we started thinking, well, what is it that's driving this difference? The other thing you can do with those death certificates, because I said you've got where somebody lived or where they lived when they died, is you can actually map geographically the distribution of death in the county. And that's what we've done here. And we've created some categories for essentially short life expectancy, intermediate life expectancy, and long life expectancy. And what you see is that death is not randomly distributed. We have hotspots of premature death in the county, which you can do, by the way, and I'll show you a little bit of data in a second, for a lot of other places as well. The death is not randomly distributed. You can predict how long somebody will live if you have their address. And I've told people that. Give me your address, I'll tell you how long you're going to live. And I'll be right most of the time. I'll be wrong sometimes. In aggregate, I'll be right. And the reason you can do that is because the things that drive life expectancy are not access to health care. They're the so-called social determinants of health, the things that essentially shape people's opportunity to be healthy. Income, education, employment, access to healthy foods, parks and recreations, et cetera, et cetera, et cetera. So the story of health is not health care. It's about people's opportunity and access to essentially the fruits of life, of which health insurance is one. Don't get me wrong. This is not an either-or situation. Okay, so the other thing that you can do is you can take the poverty map of Alameda County, and those little borders are census tracts. There's about 150 of them in Alameda County. They roughly correspond to neighborhoods. And you can take the poverty map of Alameda County and the death map of Alameda County, and you can correlate them. Basically, it's just a simple, how does death relate to poverty in the county? And when you do that, you put life expectancy on one axis, poverty on the other axis, And in an ideal world, there wouldn't be a correlation. This line should be completely flat. There shouldn't, how poor you are or how poor the neighborhood you live in shouldn't predetermine how long you live. But this is not an ideal world. And in fact, you can predict life expectancy based on neighborhood. And we did that for Alameda County. We did it for San Francisco. We did it for Contra Costa. The relationship holds. It's a very similar relationship. We did it for the 6.5 million people in the San Francisco Bay Area. The relationship holds. And in fact, you can monetize that, and you can calculate that $12,500 buys you a year of life in the San Francisco Bay Area. Yeah?
How much of this is violence?
I took out the slide that answered that question. When the life expectancy gap there, the growing life expectancy, we asked that very question, and we said, well, how much is HIV/AIDS? How much is violence? So we actually subtracted out HIV/AIDS and violence, and we found that it's less than about 6% of that difference.
So it's health. What you're really capturing is health outcomes.
Chronic disease. It's heart disease, it's cancer, it's diabetes, it's stroke, and chronic lower respiratory disease. Those are the major drivers of that life expectancy difference. It's the things that are killing African Americans, and we would do the same thing by income if we could, but we can't. We don't have that on death certificates. The things that are driving premature mortality and morbidity in those, morbidity just means sickness, in those communities are the things that are killing everybody. They're just killing those people earlier and making them sicker earlier in their lives. I showed you that there's a gradient for death. You can also look at hospitalizations. You can go to all your hospitals and ask them for what they call their discharge data. And their discharge data is basically how many people get admitted for a variety of different things. And you can see by neighborhood that people in higher poverty neighborhoods get admitted to the hospital a lot more. And that's consistent with the fact that they're sicker and that they're dying earlier. So it's consistent for hospitalizations as well. This is just that same data. We've actually mapped out hospitalizations to show where the highest intensity hospitalizations are. These are expensive hospitalizations. They're largely chronic disease-driven hospitalizations. Okay, so what is this chronic disease thing that everybody seems to be talking about? It's certainly not a major part of the debate. I mean, I went up to Capitol Hill, which was a surreal experience, and testified about in the Medicare system about the need for essentially doing chronic disease management at the county level and incentivizing it, and all you get is this ideological warfare about what the government should do and shouldn't do. But chronic disease is 3 out of every 4 healthcare dollars, which is $1.5 trillion out of the $2 trillion. And it's the major cause of death, it's the major cause of hospitalizations, it's the major cause of premature mortality, it's the major cause of health expenditure. So it is the elephant in the room. I mean, if you're not talking about chronic disease, you're not talking about health. Your accent is on the wrong syllable. So a healthcare system, a delivery system that doesn't manage chronic disease is always going to be expensive because our acute healthcare system is focused on essentially emergency room care, ICU care. It's heroic care. It's rescuing people from the brink of death or disability. And that is always going to be more expensive. Yet the prevention part of it and the primary care is going to be cheaper, it's going to be less glamorous, but it's going to save you a lot of money. To change this system requires, particularly at a county level where, you typically have emergency room doctors that are seeing, 10 or 12 uninsured patients in the ER per shift. And they are not getting paid for those patients. And they are lobbying the political processes in our county to get paid. And it's drawing money out of the primary care to pay those doctors. So changing that, it's not going to be done one county at a time. It's got to be done, there have to be incentives created at the federal level to deeply fund primary care and prevention. Otherwise, we're all sort of playing this game of just sort of throwing the money at the most compelling, immediate story and not making the deeper investment.